Hello and welcome to JCO Precision Oncology Article Insights. I'm Dr. Carolyn Lineen from St. James Hospital, Dublin, and today I'll be discussing the article Breast Neuroendocrine Carcinoma, Molecular Insights Beyond Histology by Schwartz and colleagues, recently published in JCO Precision Oncology. Primary neuroendocrine carcinoma, or NEC, of the breast is a rare and clinically challenging malignancy. One of the difficulties in studying these tumours is that historically, neuroendocrine carcinomas has often been grouped together with more conventional invasive breast carcinomas that demonstrate neuroendocrine differentiation, also known as IBC-NED. However, whether these tumours actually represent the same underlying disease biology has remained uncertain. This distinction matters clinically. There are currently no disease-specific treatment guidelines for breast neuroendocrine carcinomas. Treatment is generally extrapolated either from conventional breast cancer regimens or from approaches used for neuroendocrine carcinomas arising elsewhere, particularly small cell carcinoma. As a result, both diagnosis and treatment remain challenging. In this study, Schwartz and colleagues sought to address a fundamental question. Is primary breast neuroendocrine carcinoma simply part of a spectrum of breast cancers with neuroendocrine differentiation, or is it a biologically distinct disease? The investigators performed a retrospective analysis of 24 primary breast neuroendocrine carcinomas identified over a 20-year period and compared them with 28 grade-matched invasive breast carcinomas with neuroendocrine differentiation. Importantly, all cases underwent centralized pathology review and were classified according to contemporary WHO criteria. The investigators integrated several layers of information, including clinical pathologic characteristics, treatment response, immunohistochemistry, and genomic profiling. Targeted tumor normal next-generation sequencing using MSK Impact was available for a subset of tumors, 10 neuroendocrine carcinomas and 7 invasive breast cancers with neuroendocrine differentiation. So what did they find? First, the clinical and pathological phenotype of breast neuroendocrine carcinoma was quite distinctive. The median age at diagnosis was 53.5 years. Just over half of the tumours had small cell morphology, approximately 29% were large cell neuroendocrine carcinomas, and the remainder had mixed small cell and ductal carcinoma features. Perhaps most strikingly from a breast oncology perspective, 63% of the neuroendocrine carcinomas were estrogen receptor negative and HER2 negative. Only 1/3 were ER positive and HER2 negative. This was very different from the comparator group, in which 92% were ER positive and HER2 negative. The investigators also demonstrated response to neoadjuvant treatment. 9 patients with breast neuroendocrine carcinoma received neoadjuvant chemotherapy, most commonly with platinum-containing regimens, sometimes combined with etoposide or immunotherapy. Although all 8 evaluable patients experienced some degree of radiographic tumour reduction, none achieved a pathologic complete response. Most patients had substantial residual disease. 7 of the 9 treated tumours were classified as residual cancer burden class 2, and 4 showed no definitive histologic evidence of treatment response. Although this is a very small and heterogeneous cohort, this disconnect between radiographic response and pathologic response is noteworthy and raises the possibility that these cancers may be relatively resistant to the systemic therapies currently being used. The immunohistochemical findings were also informative. As expected, most tumours showed strong neuroendocrine marker expression. Synaptophysin was positive in 92% of cases, CD56 in 90%, and INSMI in 86%. But perhaps the most striking finding was the loss of retinoblastoma protein expression in 93% of evaluable neuroendocrine carcinomas. These were also highly proliferative tumours with a Ki67 index above 90% in 81% of cases. The genomic analysis then provided an important biologic correlate to these findings. TP53 alterations were identified in 90% of breast neuroendocrine carcinomas, compared with 33% of invasive breast cancer with neuroendocrine differentiation cancers. ORB1 alterations were present in 60% compared with 14%, although this comparison did not reach statistical significance, likely reflecting the small numbers. And importantly, half of the neuroendocrine carcinomas had concurrent TP53 and ORB1 alterations. There was also a strong relationship between genotype and phenotype. ORB1 alterations correlated with complete loss of retinoblastoma protein expression by immunohistochemistry. Together, these findings point towards disruption of the TP53 and retinoblastoma tumor suppressor pathways as a defining biological feature of breast neuroendocrine carcinoma. The genomic differences extended beyond TP53 and retinoblastoma. Alterations involving the PI3K pathway occurred in 60% of the sequenced breast neuroendocrine carcinomas and were absent from the invasive breast cancers with neuroendocrine differentiator comparator group. These included alterations in PIK3CA and PIK3OR1 as well as PTEN loss. Conversely, invasive breast carcinoma with neuroendocrine differentiation cancers showed a very different genomic pattern, with recurrent copy number alterations more characteristic of luminal breast cancer, including amplifications involving FGFR1 and CCND1. Taken together, these genomic findings suggest that these two tumors may share neuroendocrine features histologically, but their underlying biology appears quite different. Invasive breast cancer with neuroendocrine differentiation retains many of the molecular characteristics of luminal breast cancer, whereas breast neuroendocrine carcinoma appears more closely aligned with high-grade neuroendocrine carcinomas arising at other anatomical sites. Additionally, there was also some intriguing potential signals highlighted in this article. DLL3 expression was identified in 25% of evaluable breast neuroendocrine carcinomas. DLL3 has emerged as a therapeutic target in other neuroendocrine malignancies, particularly small cell lung cancer. While the numbers here are far too small to establish DLL3 as a treatment target in breast neuroendocrine carcinoma, this finding raises an interesting avenue for future investigation. Similarly, the recurrent PI3K pathway alterations identified in this study may represent another potential therapeutic vulnerability. There are, of course, important limitations. This was a retrospective study of a very rare cancer, and consequently the cohort was small. The genomic analysis was smaller again, involving only 10 neuroendocrine carcinomas and 7 invasive breast carcinomas with neuroendocrine differentiation. Treatment was heterogeneous and not standardized, which makes it difficult to draw firm conclusions about treatment efficacy. Follow-up was also considerably shorter in the neuroendocrine carcinoma cohort compared to the comparator group, limiting comparisons of long-term outcomes. Nevertheless, this study provides an important integrated view of the pathology and molecular biology of this uncommon malignancy. Ultimately, larger multi-institutional studies will be required to validate these findings and determine whether molecular classification can translate into more effective treatment strategies. But for a rare cancer in which treatment remains poorly defined, this study provides an important step towards moving beyond histology and towards a biologically informed approach to breast cancer neuroendocrine carcinoma. Thank you for listening to this episode of JCO Precision Oncology Article Insights. Until next time, thank you for listening.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.